Good day. Thanks for joining. My name is Dwight Bailey. I'm the Chief of Pediatric Critical Care Medicine at the Levine Children's Hospital in Charlotte, North Carolina. We will be speaking today on extracorporeal membrane oxygenation and organ retrieval. Can we and should we be utilizing this technology to optimize organ donation? I have no disclosures and no conflicts of interest. As I mentioned, I'm from the Levine Children's Hospital in Charlotte, North Carolina. We are a 300-bed children's hospital that opened in 2007, named a best children's hospital by the U.S. News and World Report for 13 consecutive years. We'll begin by briefly discussing the objectives. We'll review the epidemiology of growing organ demand. We'll discuss the basics of non-heart beating donation, otherwise known as donation after cardiac death. We will describe the extracorporeal interval support for organ retrieval, otherwise known as EISOR. We will define the use of EISOR support for DCD patients. And finally, we will discuss the ethics surrounding ECMO support and organ retrieval. As we look at a historical perspective, prior to the introduction of brainstem death criteria in 1968, all organ transplants were from cadaveric donors. This is non-heart beating donors, or again, otherwise known as donation after cardiac death. In 1968, the Harvard Ad Hoc Committee defined irreversible coma as brain death, equating brain death with human death. And since 1968, the primary source of organs available for transplant has come from brain dead donors. And as a result, DCD practice and donation has fallen off. As we look at data from the Eurotransplant and the United Network for Organ Sharing websites, we see a large and increasing number of registrations on the organ transplant waiting list, both within the European Union and North America. Increasing organ demand is due to a number of factors. A decrease in the number of brain dead donors, initially as a result of decreasing incidence of severe traumatic brain injury secondary to motor vehicle accidents as automobile technology and safety improves. Advances in neurocritical care management lead to a decrease in the incidence of progression to brain death following catastrophic brain injury. Additionally, improved medical care available to end-stage organ disease patients increases the opportunity for organ transplantation within these populations. The growing unmet demand for organs leads to the need for alternative sources, DCD being the most realistic and readily available. Data from the Global Observatory on Donation and Transplantation demonstrates worldwide increase in DC donors in the top left graph, and the same trends when looking at individual countries across the globe. Potential DCD patients can be classified according to the Maastricht classification, which identifies 5 categories of potential donors. Those dead on arrival to the hospital setting, those patients with unsuccessful resuscitation within the hospital setting, those awaiting cardiac arrest, those with cardiac arrest in the brain dead donor, and cardiac arrest within the hospital inpatient population. Controlled DCD is the retrieval of organs planned before death occurs, what we know as the classic DCD patient. Uncontrolled donors are those patients who have already died before consideration of organ donation. Uncontrolled DCD, although uncommon, is worth considering provided that strict protocols are instituted to minimize warm ischemia time. EISOR can be utilized in this setting to do just that. EISOR is extracorporeal interval support for organ recovery, a mechanism to maximize organ recovery and function within ECMO support. It is a novel method to improve organ viability within DCD donors. It can prevent can prevent organ damage from warm ischemia. However, it does potentially introduce new ethical issues, which we will discuss later in the talk. Let's first discuss the EISOR protocol. Initially, a withdrawal of care decision needs to occur. Following that, the ECMO cannula are placed. both the venous and arterial cannulas, the venous for blood drainage, and the arterial cannula for cold preservation fluid replacement. Systemic heparinization is not a global part of EISOR, but it is utilized in many countries and many protocols around the world. Next, the patient is withdrawn from life support, either in the ICU or the OR setting. Declaration of death occurs. ECMO support is initiated, and then thoracic aortic occlusion or lidocaine administration is performed to prevent cardiac reanimation. And finally, organ procurement occurs in the OR setting. Looking at some of the literature involving EISOR and donation after cardiac death transplantation, we first look at Li et al. From the Department of Surgery in Taipei, Taiwan. They looked at the use of renal transplants from non-heart beating donors supported with ECMO and found that the long-term allograft survival and function of kidneys from non-heart beating donors supported by ECMO did not differ significantly from heart beating donors and living related donors. Farney et al. From the Department of Surgery at Wake Forest University in the United States looked at renal and extrarenal transplantation with DCD donors with selective use of extracorporeal support. Of the 53 DCD kidney transplants performed, the incidence of delayed graft function was only 20% in those with ECMO support versus 60% in those transplants without ECMO support. And Sanchez et al. From the Department of Nephrology in Madrid, Spain, in their article on renal transplantation from non-heart beating donors, state support of the use of extracorporeal support in irreversible cardiac arrest patients to expand the kidney donor pool. Aside from the ethical considerations for organ transplantation and DCD itself, what are the other ethical concerns for EISOR? Ethical considerations of EISOR need to be divided into both pre and post-mortem. Within the ante-mortem interventions, there's the heparin administration for organ preservation itself, again, which is not a universal approach, and there is the ECMO cannula placement. And in the post-mortem environment, the ECMO support within the DCD patient is quite ethically controversial, as is the aortic occlusion of coronary and cerebral circulation and or the use of bolus lidocaine administration. Heparin administration in EISOR is particularly controversial. Opponents include the concern that patients, we can potentially hasten donor death. Actively bleeding patients may have increased rate of hemorrhage. Proponents will argue that death is potentially inevitable with or without the heparin administration, that systemic heparin provides societal benefit by improving the viability of transplanted organs, and that improvement in viability outweighs the influence that EISOR may have in the patient's manner of dying. To understand the concerns of cardiac reanimation, we need to first understand the concept of reanimation with EISOR itself. Upon post-cardiopulmonary death declaration, myocardial oxygenation and perfusion via EISOR can occur. Myocardial contractility also can occur in the absence of pulmonary and brain function. Therefore, there is the possibility of perfusion of cerebral circulation and potential neurologic recovery or neurologic awareness. However, there is no published data discussing cardiac reanimation and compatibility of life following the initiation of ECMO. The prevention of cardiac reanimation is achieved via the occlusion of coronary and cerebral circulation, either via thoracic aortic balloon pump upon initiation of ECMO. This will prevent oxygenated blood to the myocardium and thus prevent cardiac reanimation. And therefore, it will prevent perfusion of cerebral circulation and potential neurologic recovery or neurologic awareness. The administration of IV bolus lidocaine will inhibit the return of myocardial electrical activity following the return of oxygenated blood to the myocardium via ECMO. And the rationale of both of these is to reassure the medical personnel and relieve any ethical anxiety regarding reanimation. The stance of proponents of cardiac reanimation prevention include that reanimation itself occurs with ECMO initiation and the irreversible damage and possible brain death have already occurred. Some religious traditions define death as the absence of natural, unsupported breathing. Reanimation does not threaten declaration of death, as EISOR does not induce breathing. And that the insertion of the thoracic aortic balloon or lidocaine administration is acceptable, assuming that this is performed after the declaration of death. Whereas the opponents of cardiac reanimation state that no studies have been completed, there have been no large forum discussions on the use of thoracic aortic occlusion or lidocaine administration, and that these are necessary prior to EISOR and postmortem interventions are deemed acceptable. Polk et al. From the University of Michigan in the United States looked at the attitudes of the American public toward organ donation after controlled cardiac death and concluded that participants expressed more willingness to donate in the context of the controlled and uncontrolled cardiac death than they did in brain death, and that 80% of subjects would support a rapid organ recovery program in their community, though they would require family consent or a signed donor card prior to invasive procedures for organ preservation. EISOR's uncontrolled organ donation brings many societal benefits, but also many new ethical concerns. Further discussion within the medical community is necessary and appropriate to move forward with this potential organ donation method. Thank you for your time listening to the topic of extracorporeal support and organ donation. Please do not hesitate to reach out regarding any feedback, discussion, or questions.